All right, thanks so much. So I'm going to get started by talking about an overview for some of the treatment strategies for metastatic colon and rectal cancer. Just to introduce myself, my name is Luke Martin. I am the newest addition to the colon and rectal surgery faculty here at the university. I started back in September of last year. I did my residency here and then went away for fellowship and then came back. So my talk this evening is mostly going to be sort of an overview and get things started off, and hopefully it will lead to some more detailed discussion tonight. So I'm going to start with a case presentation. So this patient is a 55-year-old man with a recent diagnosis of rectal cancer on a screening colonoscopy. He has no significant past medical or surgical history. He's otherwise healthy. On physical exam in the office, it's pretty unremarkable. On digital rectal exam, he has an anterior mass that's palpable at the fingertip. And on proctoscopy, it was about 7 centimeters from the anal verge. So he underwent the standard staging workup for the NCCN guidelines. He got a CEA, which was 2,800, rectal MRI for his local staging, and then a CT chest, abdomen, pelvis, and then considering a PET CT based off any concerning lesions. So for his local staging, the rectal MRI showed a T3N0 lesion with some invasion of the mesorectal fat here. And he had a clear circumferential resection margin looking at the MRI. On his CT chest, abdomen, pelvis, there was a single liver met that was noted, but it was otherwise negative. And then he underwent a PET CT scan for a baseline to look for any other evidence of metastatic disease elsewhere. And it was only found to have the single hypermetabolic mass in the liver on the PET CT. So in terms of thinking about treatment options for this patient, he's asymptomatic, otherwise healthy 55-year-old with a mid-rectal cancer and a single liver metastasis. So typically we would start with some sort of neoadjuvant therapy in this setting per the NCCN guidelines. Oftentimes thinking about starting with systemic therapy and then radiation either before or after systemic therapy, but before surgery typically, and then either short course or long course. And there's really no right approach to the management strategy here. There are a number of consideration and various pros and cons to each of the approaches. And hopefully we will have a more nuanced discussion about this as to why we would choose one strategy versus another. And I'm going to sort of walk through some of the reasons, particularly as a surgeon, we might choose to pursue one strategy or another when we're dealing with a patient like this that has potentially resectable metastatic disease. So I'm going to talk about these strategies in a bit more detail, just to break it down. So first, thinking about patients with a rectal primary. In these patients, they're almost always getting some sort of neoadjuvant treatment before surgical intervention. For some patients, we may choose systemic chemotherapy followed by radiation, either short course or more traditional radiation, and then either a synchronous or a staged resection of the liver and the rectal primary. For some of these patients, we may choose radiation therapy first, followed by chemo, and then the staged resection. And then in patients who are presenting with either an obstructed or a perforated cancer, oftentimes these patients are getting either diversion or a stent, followed by systemic therapy and radiation, and then either a synchronous or a staged resection. And there's a lot of nuance, again, as to why we would choose one strategy versus another. For example, factors that may influence our choice are whether or not they have a locally advanced tumor, whether or not there's a threatened circumferential margin, how symptomatic the primary is, how much of the liver is being resected, whether it's a formal lobe or a wedge resection, how low is the potential anastomosis, is the patient otherwise healthy, do they have any other underlying liver disease, and various other patient-specific factors. In terms of thinking about patients that have a colon primary, I think unlike rectal cancer, there's a potential choice for choosing all the surgery up front. And I think that's probably the primary difference between the potential choices for management strategies of a rectal primary versus a colon primary. Although very often these patients are getting neoadjuvant systemic therapy of some sort before resection, but in certain scenarios, they would potentially have surgery up front. So in terms of thinking about the primary resection first, it may be that they have a colon resection followed by chemo and then liver resection, or sequential surgeries followed by adjuvant chemotherapy. In some patients, they may undergo a synchronous resection first, followed by adjuvant chemotherapy. And some patients may get a liver first surgery, followed by colon surgery or chemotherapy. And finally, they may get systemic chemotherapy, followed by either a synchronous or a sage resection. And, I think the point here is that there's a real broad variety of sequencing options. And there are a lot of patient-specific and tumor-specific factors that may push us in one direction or another. And hopefully we can touch on that in more detail in all of the individual patient discussions tonight. Again, it comes back, I think, as a surgeon we think about whether or not the primary is symptomatic, whether it's bleeding, whether there's an impending obstruction, various patient-specific factors that may place them at higher risk for operative morbidity. And for patients undergoing liver surgery, the amount of liver involved and whether or not they have any underlying liver disease. So getting more specific in terms of thinking about why we might choose to do surgery first on a patient before any sort of systemic therapy or other treatment. The advantages to this is that it avoids any potential complications or progression of the primary tumor while the patient is on chemotherapy or recovering from a hepatic resection, such as a perforation or progression of disease such that it becomes unresectable. And it addresses the symptoms that the patient's having, whether those be obstruction or bleeding or other symptoms. The disadvantages here are that the patient may have progression of the liver during their postoperative recovery from surgery. And if they may, this may delay systemic chemotherapy, especially if they have any complications related to their surgery. And overall, there are fewer patients who complete the entire treatment sequencing if we start with surgery first. But consideration should be given to surgery first for symptomatic primary tumors, especially. In terms of thinking about a synchronous resection for patients, the advantages here are that it removes all the malignancy in a single operation, and that's the primary advantage. The primary disadvantage is with this larger surgery comes significant operative morbidity, with up to 50% or more morbidity, depending on the extent of the associated liver resection. And this, of course, risk delays in systemic therapy with any sort of perioperative complications that delay the individual's ability to get systemic therapy. And there's some data that there's worse progression-free survival doing synchronous resection compared with sequential resections, which overall have very similar morbidity as doing one synchronous resection. And I think the considerations here are for a colorectal resection where you're just doing a very limited wedge resection of the liver, or potentially if you're doing a more extensive liver resection for the really straightforward, easy segmental colectomy in patients who are potentially otherwise healthy. Certainly with a synchronous resection, we would give very careful consideration to stoma creation, whether we do a diverting loop ileostomy to protect an anastomosis or doing a Hartmann's procedure, depending on the extent of the resection and the level of the anastomosis. For patients who are getting systemic chemotherapy first, the advantage here is early initiation of systemic therapy, obviously, with low risk for disease progression and potential downstaging of the liver or the primary. And looking at patients who start with this type of strategy, more of them are completing all of the sequences of care as opposed to only getting surgery and then not getting any systemic therapy. The disadvantages here are potential progression either of the liver or the primary, or complications related to the primary, whether it be perforation or fistulizing or bleeding while on chemotherapy, with more difficult surgery as a result of concurrent chemotherapy and a need for an urgent surgical intervention. Another potential disadvantage is liver toxicity of the chemotherapy, but this is often the most appropriate strategy for patients with asymptomatic primary tumors who have metastatic disease and are potentially resectable. I think the point here is that many of these disadvantages may really not actually be disadvantageous, as if you've got a patient that's progressing on chemo, then it may signal something about the underlying tumor biology when surgery might have been of limited benefit anyway. And then finally, thinking about a liver-first approach, the advantages here are that it avoids chemotherapy-induced hepatotoxicity and the often very difficult task of identifying a regressed hepatic lesion intraoperatively. The disadvantages are progression of the primary or disease elsewhere and delays in systemic treatment associated with any sort of perioperative complications. So that in terms of going back to our case presentation, so this patient that was the otherwise healthy 55-year-old man, he got 4 months of FOLFOX and Avastin, followed by a restaging PET CT, which showed a dramatic response in the liver. He then underwent a right liver lobectomy, then short course radiation therapy 5 weeks after completing surgery, followed by laparoscopic low anterior resection and a loop ileostomy 10 days after short course. And then finally, adjuvant chemotherapy with FOLFOX starting 5 weeks after the low anterior resection. And then after completing that, closure of his loop ileostomy. So his final pathology showed a 5.5 centimeter liver met with negative margins and a YPT1 N1 rectal cancer with 3 out of 13 positive nodes with perineural invasion, and his post-op CEA was 2.1. So I think really in terms of thinking about the overall picture of sequencing, there's a lot of treatment options that are available and for patients who have potentially resectable metastatic colon and rectal cancer. And there's not any data to say which is the optimal treatment strategy. It really has to be patient specific and oftentimes is driven by the primary and whether or not they're symptomatic, and if so, what symptoms they're having and where the primary is located. And this really has to be an individualized discussion using a multidisciplinary approach. And that's all I've got.